Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today I briefly cover on the topic tetralogy of Fallot. Tetralogy of Fallot is the most common cyanotic congenital heart disease, constituting 10% of the congenital heart diseases. There are four important components in tetralogy of Fallot, that is pulmonary stenosis, ventricular septal defect, overriding of the aorta, and hypertrophy of the right ventricle. Pulmonary stenosis. Pulmonary stenosis is the most determining factor for the severity of the tetralogy of Fallot. Pulmonary stenosis occurs at the infant blood level. Sometimes it could be valvular stenosis. Valve could be bicuspid. There could be sometimes pulmonary branch stenosis. Pulmonary infant blood stenosis occurs as a result of the anterior deviation of the outflow septum. With the anterior deviation of the outflow septum, there is a compression over the right ventricular outflow tract. That results in a pulmonary stenosis. Then there is malaligned ventricular septal defect that results in the overriding of the aorta. Aorta opens into both the ventricles and receiving the blood from the right ventricle and the left ventricle, and mixed blood flows into the systemic circulation. Because there is obstruction to the right ventricular outflow tract, right ventricle develops thickening of its walls. Well, the severity of the Fallot tetralogy depends on degree of right ventricular outflow obstruction. If the obstruction is mild, there is development of a situation called pink Fallot, and baby may present with the signs of congestive heart failure. If the obstruction is severe, there is no pulmonary flow, and child may develop severe stenosis, and the pulmonary circulation depends on the presence of patent ductus arteriosus. Well, coming to the etiological factors. Etiology is not known in this particular condition, but there are certain risk factors to mention. Maternal age, in maternal age more than 35 years, there is a risk of developing tetralogy of Fallot. Maternal diabetes mellitus, maternal smoking, congenital rubella infection, and certain chromosomal and genetic abnormalities like Down syndrome and DiGeorge syndrome. Coming to the pathophysiology. Severity of the tetralogy of Fallot, as I told already, depends upon the degree of pulmonary stenosis. Venous return occurs to the right atrium from superior and inferior vena cava as usual, and blood flows from the right atrium into the right ventricle. And as there is obstruction to the right ventricular outflow, and blood is shunted from the right ventricle into the left ventricle into the overriding aorta, and deoxygenated blood from the right ventricle gets mixed with the oxygenated blood that is coming from the left ventricle, and the systemic circulation contains the mixed blood. And child presents with the cyanosis, that is central cyanosis. What are the clinical presentation? In the neonatal period, during the early childhood, and later part of the childhood. How the neonate presents? There could be signs of congestive heart failure if pulmonary stenosis is mild and there is good pulmonary circulation, and the degree of cyanosis will be mild. If pulmonary stenosis is severe, and the newborn may present with signs of shock and severe cyanosis and metabolic acidosis, and it is a critical emergency situation that newborn should be shifted to the center for expert management and surgical correction. Well, as the baby is growing, during early childhood, there may be signs of growth failure, and baby may suffer from exercise intolerance and breathlessness during the play activity, and baby takes squatting position to get relieved of the breathlessness. And baby may suffer from signs of hypoxic spell, sudden development of severe breathlessness, generalized cyanosis, losing sensorium, sometimes convulsions and paralysis are some of the features of hypoxic spell. This is also called test spell. These spells are more common between 2 to 4 years of age or earlier than that in babies with mild to moderate degree of tetralogy of Fallot. Because these babies fail to develop compensatory mechanism of polycythemia as the anomaly is mild. These are the children described as pink fellows who develop the paroxysmal hypoxic spell more frequently than the children with moderately severe form of tetralogy of Fallot. Well, child may develop clubbing of the fingers and toes because of the chronic hypoxia. When you examine the child, there is growth failure, clubbing of the fingers, central cyanosis with bluish discoloration of the mucous membrane and the peripheries. There is a precordial bulge and systolic thrill over the precordium, and the harsh systolic murmur at the left lower sternum and the pulmonic area. Second sound is diminution in intensity. Well, these are the clinical features of tetralogy of Fallot. What are the diagnostic workups you do for this child with tetralogy of Fallot? X-ray chest, ECG, and 2D echo. X-ray chest shows boot-shaped heart because apex is rounded because of the right ventricular hypertrophy, and it is lifted off the diaphragm, giving a boot-shaped cardiac shell hearting. There is an oligemic lung fields in the X-ray. Well, ECG shows right ventricular hypertrophy and right axis deviation. 2D echo is diagnostic, showing all the anomalies described under tetralogy of Fallot. You will see the large ventricular septal defect, and there is a right ventricular outflow obstruction in the form of pulmonary stenosis, and you will find the ventricular septal defect. 2D echo confirms the diagnosis, and we will go to the treatment. Treatment is surgical and the medical management. Medical management of the hypoxic spells which is a clinical emergency. How do you deal with the child with the hypoxic spell? Keep the child in the knee elbow position, loosen the dress. This will help the child as there is peripheral vascular resistance is increased when the baby is kept in knee elbow position. That results in the degree of right to left shunt, and child will be relieved of hypoxia and improve with regard to breathlessness. Give oxygen, and injection of propranolol will cause the peripheral vascular constriction and increase the systemic vascular resistance. And injection of morphia to reduce the apprehension and irritability in the child. And advocate early surgery in order to avoid morbidity and mortality. And if the pH is low and PaO2 is less than 40 mmHg, give injection bicarbonate. With these steps, child more or less is going to show improvement. In resistant cases, you may go for intubation. Well, this is the line of management of the child admitted for TET spell. Then, what are the complications the child may go into in tetralogy of Fallot? Number 1 is the cerebral thrombosis. Number 2, brain abscess. Number 3, infective endocarditis. Number 4, congestive heart failure. These are the 4 important complications the child may develop if untreated. Well, to avoid cerebral thrombosis, prevent development of polycythemia, give iron to reduce the frequency of paroxysmal hypoxic spells. Then advocate prophylaxis for infective endocarditis. And by and large, advise early surgery. What are the surgical steps that are being carried out for the children with tetralogy of Fallot? 1 is palliative, number 2 is the total correction. Palliative surgeries are nowadays not advocated. Earlier they used to do this shunting, connecting the subclavian with the descending aorta, ipsilateral descending aorta, like Blalock Taussig or modified Blalock Taussig. But nowadays, total surgery is advocated, wherein patch closure of the ventricular septal defect with resection of the right infundibular obstruction. With this, children improve dramatically, and they have the catch-up growth and good exercise tolerance. And post-operative mortality is less than 5%. Sometimes they may develop certain complications like pulmonary insufficiency, aortic insufficiency, and restenosis of the pulmonary stenosis, which can be corrected by surgical intervention. Well, coming to the various pictures showing the features of tetralogy of Fallot. This is the picture showing the components of the tetralogy of Fallot. That is the infundibulous stenosis, ventricular septal defect, overriding of the aorta, and right ventricular hypertrophy. Here, the main important determinant of developing these anomalies is the anterior deviation of this outlet septum that results in the compression of the right ventricular outflow tract. Then further development of the malaligned ventricular septal defect. And when there is a support for the base of the aorta is lost, and there is a tendency of the rightward shift of the base of the aorta. That results in the overending of the aortic opening, and aorta opens into the right as well as left ventricles. This is also a picture showing the right ventricular outflow obstruction, large ventricular septal defect, and overriding of the aorta. This is the oxygenated blood in the left ventricle, deoxygenated blood in the right ventricle, and mixed blood flowing into the systemic circulation through the aorta. This is the 2D echo of the tetralogy of Fallot, showing the left ventricle, right ventricle, and the ventricular septal defect and overriding of the aorta. This is the baby admitted into the emergency service with TET smell. Baby is severely dyspneic and generalized cyanosis and respiratory distress, and attended to in the emergency and managed with the emergency care. Oxygen is administered, injection morphine, and injection propranolol, putting the patient in knee elbow position, and oxygen delivery, injection back of net. All these steps of the emergency management have been carried out to get the child improved. This is the X-ray chest of the tetralogy Fallot showing boot-shaped cardiac shell artery with all given lung feeds. ECG is showing right ventricular hypertrophy and the right axis deviation. Well, this is how the patient with the tetralogy of Fallot presents to you, and the important steps of management, and with the total correction of the anomaly, child is going to improve well, and growth, they catch the growth, and most of the complications of the tetralogy of Fallot can be averted by early correction of the anomaly. That's how nowadays the baby with the tetralogy of Fallot is managed in order to avoid the mortality. Thank you very much for patient listening, and we'll meet again in the next class. Until that time, bye-bye.